background of me. I am a 1992 graduate of Conner-Weiser High School. And probably if you would have asked me when I was a senior in high school if I was going to be a physician or a surgeon, I would have laughed at you. This is not what I anticipated doing every day of my life, but I'm so rewarded by what I do. I love my job. I never have the same day twice because I never have the same patients twice. So I like to do some fun things. I forgot to open the other ones. I like to do a little quiz, but these are fun quizzes. Just you may or may not know some of the answers, but I have prizes if you get them right. So, and most people like candy, so at least my daughter told me that I should have this. So I am Megan Shannon, formerly Megan Evans. That most people know me at Weiser with that, but Dr. Shannon, but more importantly, Paige and Leah Shannon's mom. So Paige is going into 8th grade, and then I have a younger daughter going into 4th grade, Leah. So when I was heading into my senior year, basically you're forced with trying to decide what you want to do for the rest of your life, and I decided I wanted to work with people. Really didn't want to do some of the counseling kind of things. I wasn't sure what I wanted to do, so anybody want to take a guess what I thought I wanted my major to be? Go ahead.
A doctor.
No, never a doctor. That was one thing, if you would have asked me that, I definitely did not see myself as that.
An RN?
RN, no. I didn't really want to do nursing.
Accounting?
Counting, no. I was not a math person. I didn't love math. In fact, my geometry teacher, I told him that I would never use geometry ever.
And
I use geometry every single day of my life, looking at angles and things like that. So I had to see him at a fair a couple years ago and tell him that he was absolutely correct, and I use this every day of my life, as much as I told him that I didn't see the 3D imaging. But something in the medical field, but not a doctor. Does that give anybody a hint?
Someone who studies eyes?
No.
Physical therapist?
Yes, I actually, Hershey's, Skittles, or M&M's?
Skills.
Skittles? All right. So yeah, I thought I was into, actually went to school on a field hockey scholarship, so I was interested in sports. So that's kind of what led me along the lines of physical therapy. I tied those together. I spent some time shadowing. And what I would encourage all of you to do if you are considering a career, this is awesome because you get a lot of different venues of careers, but go shadow people. Even if it's something that you don't think you want to do, if you think you want to go into medicine, if you have the opportunity to shadow somebody, please do that, because I shadowed people, that's what made me decide not to do physical therapy. So, anybody want to guess when I changed my major? You got 4 years to decide. Go ahead.
Junior year?
Spring of my sophomore year, so you were close. I decided to change it. Basically, Hershey?
Yeah, sure.
Okay.
Thanks.
I decided to change my major, which was really scary. So at that point, I looked at our course catalog book. I had had some major injuries to my foot and ankle throughout my field hockey career at that point. And just from having experience working with foot and ankle specialists, that's what I decided to do. But I also had, a physical therapist kind of tell me to change my whole course of where I was going, and at that point I thought, this is not what I want to do. Looked at our course catalog book. We had a pre-podiatry program. We had a sister program with the Temple School, and that's when I decided to change my major. So it's never too late to change your major, but certainly it could take a little longer. I still graduated in 4 years. My dad gave me that deadline. Anything beyond that, I had to pay for myself. So I had 4 years that he was helping me pay for. So we'll kind of go through some of these cases later. I don't like to bore you with all kinds of numbers and things like that. I like to do cases so you can actually see what we do. And I think that's really important. So, next question. Some of you saw me in the middle school when we did the career day with you, but Anybody know how many bones are in the foot? You can't answer. Take a guess. 210, too many. 54, too many.
23.
Too little. But close. We might have to give you an honorary candy just for that. 28, you got it. M&M's, Hershey, or Skittles?
Skittles.
Skittles. Yeah, there's 28 bones in the foot. Yeah. So there's a lot of bones in the foot to deal with. And we do such a wide variety. We look at dermatology, which is the skin. We look at vascular disease, which is the blood flow. We look at rheumatology, which is dealing with like different autoimmune type of things. We look at infectious disease, which is dealing with infections or treating infections. We look at orthopedics, which is bones and breaking those things. We also do soft tissue, tendons, repairs. We have traumas. Anybody give me some traumas that we might see?
Compound fractures.
Compound fractures from skateboarding accidents, from sporting accidents, things like that. What do you want?
I don't need another one.
All right, any other traumas? What would be a trauma that the emergency room would call me about? That their foot got cut off? Correct. You want to come get one?
Broken bone.
Broken bone, you get another one? Traumas, something huge, big.
Foot infection?
That would be another one, you get candy. What?
Heart attacks.
I wouldn't treat a heart attack. You might have a heart attack if you see some of the infections that happen in the foot, but I would not treat a heart attack. That would be with a cardiologist. I just do foot and ankle.
They got like a piece of metal stuck in their foot.
Foreign bodies, yeah, you can have that.
Getting run over by a lawnmower.
Getting run over by a lawnmower, that's correct. We do see that at least once or twice this summer. You'd be amazed how many people run over their feet with a lawnmower. You can have candy. Go ahead. Sprain your ankle, but not necessarily a trauma that hurts, but bigger. Something that would have to like be seen or treated immediately that day.
If you like got impaled by like a nail or something.
True, that is very uncomfortable, and we would need to take care of that right away. Go ahead. Chip bone, yeah. I'll give you, you're thinking, so I'm going to give you candy for that.
An infected wound.
Infected wound, yes.
Lots of pollution in the foot.
Very good. So bigger than that. What do some people like to do for sport in the city of Reading? I don't know. Sometimes gunshot wounds, right? We've had our share of that. Typically, when we're involved with, the warning shot when they shoot is at the feet, and then they start to run. So we tend to get, we've had BB gun injuries. We've had not only lawnmowers, but we've had people get crush injuries where they've been run over by vehicles, run over by forklifts. Drop very heavy objects at work and things like that. So there's a lot of different things we do. Yes.
You know like diseases where someone's foot can get ingrown?
Their foot can get ingrown or their toenails can get ingrown.
Oh yeah, the toenails can get ingrown.
Yeah, that's pretty common. We see a lot of people with ingrown toenails. So we'll go back to some of these pictures here. But these are all different examples that we have done surgery. I'll kind of show you. We'll go back to that slide. So basically, you have to have a BS or a BA, which is a bachelor's degree, which is about 4 years. You can major in anything as long as you take your core curriculum. They specifically tell you what classes you need to take, prerequisites, biology, chemistry, physics. Obviously, you're heavily laden with a lot of these sciences. So a lot of what you're seeing here, and I always tell everybody, I was kind of a pseudo-biologist. I had to take the ecology and look at like the earth science, but I never really liked that stuff. I can remember being out in the field in a lab looking at bark and birds, and I really had no idea what I was doing. But if you gave me like bones, I could put them together, and tendons, and my friends that like that side of biology were like, how do you do that? And I was like, I don't know how you can look at bark and tell me what it is. So y'all just have to find your interest and where it lies. Science is such a huge area, and there's a lot of things that kind of overlap. So as long as you have your core requisites, you can have an accounting degree, but as long as you have your sciences, you can go back and do that. You have to take this test called MCAT, similar to like an SAT or something like that. It's a pretty arduous test. MCATs are required for medical schools. Most medical schools use that as well. So it's the same test. I think, if I remember correctly, it was about a 4 or 5 hour test. It's pretty grueling, but once you have enough requisites for that, then you go to podiatric medical school. There's 9 now in the country. When I was there was only 7. Most of them have buddied up with a major university. So I went to one in Ohio, but now that is called Kent State. We also have one in Pennsylvania. It's affiliated with Temple. So most of the schools have gone to that. Your first 2 years are basically most of your sciences, but they also do, we're a little different from medical school. There's 3 different courses that we don't take, but you still have to take all of the human body, and we have to learn the whole body, because a lot of problems that happen in the foot come from issues like the heart, or the vascular, or rheumatology affects the whole body. Infections can affect the whole body. So we have to work with all of those individuals and know, if people are on certain medications, we can't give them certain medications. So there's a lot of things that cross over with medicine. So your third and fourth year, we do clinical rotations. So you're either based out of a clinic in the area of the school, or you travel abroad. Some of the places that I went to, and it's kind of a twofold purpose. You go to places that you'd like to carry on your education, so you want to show yourself. And that's where your handshakes come in, very important. We always called it a dead fish handshake. And being a female in a predominantly male-dominated career, that was one thing that one of my attendings said to me. Never show them that you're a girl, you're an equal. You want to be equally as strong as any of the males that are, kind of domineering in this area. So look them in the eye and shake with a firm handshake. And I probably surprised some people, but that's really important. It just shows that you believe in yourself. And if you believe in yourself, you can achieve anything that you want to do. So I went to Salt Lake City, I went to San Antonio, I was in another part of Ohio, I was in Mountain Home, Tennessee. I actually did one of my rotations here in Reading. So you can travel across the country to go see different programs. And like I said, you're working up and doing patient workup, but also you're kind of showing yourself to the residency programs. Throughout your career, you have in your medical school, you have 3 different tests that you have to pass in order to graduate and get your doctorate. So at the end of your medical school, you are a full-fledged doctorate. Then you have to go to a mandated 3-year residency program. So fortunately, we started 5 years ago. We started a residency program here at Reading Hospital. We have 6 residents, 2 per year, and they're actually adding that. It's pretty exciting. There's a lot of changes going on. I don't know if you all heard, Drexel is bringing a medical school here to Reading. And there's a lot of talk at the hospital that they're adding multiple different specialties, bringing it in. I was telling some of the folks, we are in the top 7 hospitals in the country as far as busiest ERs in Reading. So considering it's kind of a smaller, it's a level 2 trauma center, but we see a lot of patients through our doors. From the time that we started our residency program till now, the number of patients we see in podiatry alone is about 80% increase since we started our residency program, because they know what we can do. They don't turf things off to anybody else. We get all those different things. So usually your first year you rotate through vascular medicine, psychology, infectious disease, rheumatology, where else do we go? You name it, radiology, emergency medicine, internal medicine. You work with all the other docs. You're not just doing foot and ankle. You are doing full-fledged medicine. They expect you to know everything about the body as well. Then your second and third year, and sometimes your first year if you're in podiatry, you do rotate and learn your surgical skills. So I have a resident that works right with me and does the surgery, and I overshadow them and see what they're doing and making sure that they are doing that. They have their own clinic that they run at the hospital twice a week. And I know for myself, I logged about 1,000 surgical cases before I graduated and started on my own. So fellowship's optional. There's different fellowships throughout the country. There's also what we call an external fixator, where they go into Russia and they work with Elizarov, and I'll show you one of the frames that is. So there's lots of different opportunities to kind of travel. So different types of practices. You can be in practice by yourself. My husband and I work together. We met in medical school, not what I anticipated, but you can't help who you fall in love with. And we are in a group practice. We have 7 doctors, 2 different offices. We have some people that are just associates and others that are partners. So there's a lot of different types of groups. You can be hospital employed, where you're just seeing patients in the hospital. Multi-specialty, that you work with other practices like vascular surgeons, orthopedics, things like that. Or just an orthopedic group where some people specialize in hands, hips, knees, and you're a foot and ankle specialist. So there's lots of different types of groups that you can be in. I never wanted to be a solo practitioner. Essentially, you know, if you're out on a vacation or when I'm on maternity leave, I had somebody to help kind of cover my patients. I know they're in good hands when I leave. So, income. A lot of people kind of ask that question, like, what can you make? And that's kind of important when some people choose their careers. I don't think it should be the first thing that you choose, but there's some variabilities. It depends on how long you've been in practice, whether you're an associate or a partner. If you're an associate, you're working for someone, you're just getting a salary. If you're a partner, you're involved in more investments. You own your buildings and things like that. You own the practice. There are multiple surgery centers that you can be in partnership with. So basically, what the income that comes in with the surgery center, you get a percentage of that income. Obviously, overhead costs, it's expensive. It's expensive to have a practice, to pay for your employees, to pay for health insurance, to pay for malpractice. Our cleaning bill at our office alone is $37,000 a year because we have somebody coming in, but it's really, really important to have a very clean, sterile environment. So all those things are expensive, and you have to kind of account for that. So there's, whether you work in a hospital, you're solo, in this day and age, a lot of healthcare professionals are going with hospitals because they have someone that they can pay hourly to come in and clean your office versus having to do it yourself. So a lot of people go, oh, the Reading Hospital took over another doctor's office. Sometimes it's a matter of it's just more financially feasible for someone to work for a hospital versus having to incur all those costs yourself. So this is, my residents pulled this up for me, just to kind of give you an average of the 90th percentile down to the 10th percentile of the different wages. If you work hard, the harder you work, the more you will probably bring in. Most things are based on you get a salary and then you get an incentivized salary that if you hit a certain percentage, then you get more. So the harder you work, the more you can make. The little you work, you can make less. It's really variable. What do I like about being in private practice and being my own boss is, I am my own boss. I can work as hard as I want, but I don't feel guilty if I want to go and present at a science research institute. I think it's important to give back. So we do a lot of this. We do allow students to come in and shadow. I don't care if you don't want to do podiatry. If people give you the opportunity to go shadow and you think you want to do something in medicine, take that opportunity and go spend a day with them and just see what it's about. because if you can't stand the sight of blood and you find out very early, my nephew thought he wanted to be a state trooper. He spent one day working in the back of my office and got very sick from a smell. He realized that that wasn't the career choice for him. So, you know, take those opportunities and run with them. So let's get into the fun stuff. So the first case is a flat foot deformity. Anybody know what a flat foot deformity is?
It's when your arch is flat and
Correct.
I have a flat foot.
You have flat foot. All right. So if we look here, we can see that he's pretty much flat as a pancake. There is no real arch height. Anybody see anything Anybody see anything crazy over on this slide that looks like sort of abnormal? This toe is very bent and curled. So you two can come up and get some candy because you have good answers there. So that toe is kind of hooked, and it should not be like that. So not all patients that have flat foot deformities have to have surgery. Some people can have what's called flexible flat foot, which means that the soft tissue doesn't hold up their foot and support it, meaning their tendons and fascia does not hold it up, or they can have a bony flat foot deformity, like that. So this patient was a surgical patient. You can see the top picture is before, the bottom picture is after. They had a very, very painful tendon that had to work twice as hard to kind of pull the foot up into position. We see that there's no arch at all. When we recreated it, we created a little osteotomy to the calcaneus here. And we used screws. So I know one of your teachers was asking me what kind of screw, what is it made out of? Stainless steel. So even if you're not into medicine on this side, doing engineering or biomedical engineering is really a big thing to come up with different types of devices that we can use. We also had to fix the curved toe there, and we had an osteotomy. That's where we call a bone cut. So you look at, this is an AP view. We're looking from the top down when we do it. We corrected the curved bone. So we had to fuse that portion of the metatarsal cuneiform joint here so that we got that back into alignment. You see now that that's nice and straight. We also had to do an osteotomy of the metatarsal head. And you'll see that there's a little screw on this second one. You have something called a metatarsal parabola. The metatarsals are the long bones of each of the toes. And it's supposed to create a nice arch. So the first metatarsal is supposed to be longer than the second metatarsal is supposed to be longer than the third is supposed to be longer than the fourth is supposed to be longer than the fifth, in reality. That's how it's supposed to work. Obviously, if you look up here, I know it's not the greatest imaging, but we can see that there's a couple millimeter difference, and this second metatarsal is really, really long. So you have to correct that so you don't have a pressure point that the patient is walking and getting more pain underneath that second one. Get a painful callus or something that really hurts every time they walk on it. So on the back, the rear foot, we see that we lengthen that column, the lateral column of the foot, so that the foot can be turned and brought into the position it needs to. So that's an example of a flat foot deformity. All right, anybody see anything wrong on this over here? Anything kind of look out of whack?
There's like a chip on the heel.
There is. Very good. You get a candy there, Ben. So not only do we have a prominence here, but we have this huge spur, and that's right where the Achilles tendon inserts into the foot. I always kind of tell my patients when they're talking about different types of issues, I always say in an engine or in a belt, if you have a stone that's in that belt and it's going over that, it's supposed to be a smooth surface as it's going over that, that's kind of what the Achilles is doing over that spur. It just grinds and grates over that. I have patients that come in and they just have pain every day. It's interesting because I had a landscaper that I saw about 5 years ago. I said, you've got this, but you can live with it. You can live with it as long as you can deal with it. And at that time, he owned his own company. He said, I'm not ready to have surgery because this requires about an 8 to 12 week recovery, and that's the beginning of a 6-month recovery. So 8 to 12 weeks, you're non-weight bearing, not putting any weight on this for 6 weeks. Then you go to partial weight bearing, which means with a walker or crutches and a cast boot, and then closer to that 12 week, you get back into regular shoes. So it's a big deal, because what we have to do is go in and split a portion of the Achilles. And then we have to reattach the Achilles after we shave the prominence off. So I just saw him back 5 years later. He said, I can't deal with this, I have pain every day. I need to get this surgically done. And he kind of worked it out that he's got less time because he now manages and supervises crews that go out, but he needs to have it done before winter because that's when he drives and plows. So he lays off a lot of his guys for the winter time, so he needs to be back and ready for that. So these are kind of dark, but you can kind of see how this is nice and smooth over here. We shaved all those prominences, and if you see this little thing right here, some of you that did the career day with me over at the middle school, you guys were able to put some of these into bone models. That's actually a bone anchor, a tendon anchor. It screws into the calcaneus, or the heel bone. It has non-absorbable suture attached to it, and that non-absorbable suture reattaches that Achilles back down so that it's functional and working. So I know Ben did the career day, you got to play around with that, Paige was there, and I see a couple familiar faces with that. So, wound care. You guys are doing a lot of research right now with different dressings. We see a lot of that. We see it with diabetics. A lot of diabetics lose sensation to their feet. It's one of the complications when blood sugars are elevated. They actually attack the capillaries or the blood vessels that feed and nourish the nerves. When we take away that nourishment, people lose the sensation to their feet. I've had people that go down to the beach for their summer vacation. They go out on the beach. They don't realize how hot the sand is because they can't feel the bottom of their feet, and they burn the bottom of their feet. You or I, we run through the sand because it hurts, but not everybody has that. Sometimes there can also be spinal issues where we have impingement of the spine on the nerve, and the nerves lose sensation to the feet because of that. Infections can cause nerve damage, blood flow issues. When people don't have enough blood flow, they can't heal wounds. And pressure. Simple things like just sitting on a lazy boy watching TV can cause a wound. When we ache or we hurt, we move positions, right? Some of these people can't feel that to do that. So this is a pretty gnarly looking heel. It's kind of upside down, so I apologize. This is actually the bottom of the foot. This is a portion of the Achilles sticking out. This person could not, now you can thank my resident because Paige asked for a lot of gory pictures today, but they didn't put them in. So, but obviously this is a problem. This is not the color that your skin should be. This is necrotic or loss of vascularity to the skin. The Achilles is exposed. That Achilles sits right on the bone like we saw in the last case where that bone spur was. So this is an infection. Unfortunately for this person, the bone was infected underneath, that heel bone was infected. So most important thing, we work with infectious disease to make sure we have the right antibiotics. But this person had to go to surgery. We also had to work with vascular medicine because obviously you or I should not have anything that looks black on our skin. So once we get the vascular supply going back down to the feet, then we do surgeries. So what happened was they had to have a portion of their calcaneus taken off, the back of their heel bone, a portion of their Achilles taken off, and we put the wound back together. They had long-term IV antibiotic therapy with usually about 6 weeks. That requires that, and the patient healed the wound over a course of about a month. So obviously, I do a lot of amputations, but that's not my favorite surgery to do. It's kind of mindless. We like to salvage and try and keep everybody with a functional foot. That's our goal. Unfortunately, sometimes they end up losing their legs. That was one of my things when I went into podiatry. People said, why would you go into podiatry? I typically don't have to tell my patients that they're going to lose their life. There's times where they're stubborn and they don't listen to me, and I have to say to them, if you keep going with this infection, it will kill you. But usually the worst I have to tell them is that they may lose a body part, and that's a whole lot better than telling them they have to lose their life. But sometimes you have to take a hard road with them on a hard line, which I don't like to do, but I do. So this is a patient that I had very early in the summer. He was down at the beach and he fell off some rocks. And anybody see anything wrong? I have one prize left.
It looks sort of like his leg is going a little bit farther out to his.
You're correct. And this is actually after they've reduced it. He fell and broke his ankle, but he also dislocated his ankle. So you get the last two M&Ms. So he's a healthy guy. He comes to my office and breathing in pain because when I actually took an x-ray of him, they supposedly put him back together, but they sent him out and his ankle was not back together. So I had to send him to the emergency room to have them try and get it back in alignment because when it's dislocated, it's very, very painful. And this is a little hard to see, but he has a spiral oblique fracture here. And obviously, this should not be sitting out like that. We had to wait a week to actually do surgery at that point. He wanted to come back home and have the surgery done. He knew he was going to need surgery, but the problem was swelling started to occur, and you have to worry about something called a fracture blister, where the skin swells and the soft tissue swells so much that you get blisters on your skin, much like when you get a rubbing irritation from a cleat the first time you wear it or a new shoe. This is a huge blood-filled blister because there's so much swelling, the skin can't tolerate it and handle it. So, because we had not only the fracture, we fixed the fracture over here using plates and screws. This was a clamp holding everything together, and this is a wire that goes through the tibia, and then it has like a button on the outside that we pull and suck the syndesmosis, or the syndesmosis is the space, the soft tissue space between the fibula and the tibia. But if that's too wide, we need to bring it back so the patient can function. He's now starting physical therapy. This is called a tightrope, essentially because it's a rope that looks like a tightrope in there. It's a wire that goes through and keeps everything nice and snug. This is an unfortunate accident. A gentleman was out hunting out in the middle of the woods and fell from his deer stand. So he went to the emergency room, and unfortunately, the emergency room missed the diagnosis. Our residents were called in, and he got further imaging. And anybody watch football or anything, you hear a lot about Liz Frank injuries. The Liz Frank is the cornerstone, or the keystone from the forefoot to the rear foot. So I don't know if you can see it, but right here, all of these metatarsals are fractured, and this is kind of shifted laterally. We have a big space in here. We should not have that. So my residents were called in. They got the CT scan and saw this. So the gentleman had to go for surgery and had to realign everything. We had a plate and screws put in to hold everything back in alignment. These wires that you see, because if I go back, I don't know if you, sorry, if I go back, these are in lots of different pieces. Unfortunately, sometimes you just can't get a screw to hold that. So that's where they use the pins, and those go through your skin. They're called percutaneous. Go through the skin, and it just holds everything in alignment until everything can kind of heal itself. Then those get pulled. Okay? So not only, that was the right side, but unfortunately this gentleman fractured his left heel. When he came down, he landed on his left heel and squished it. So just like you were looking at the flat foot deformity before, basically think about all your weight coming down about, I don't know how high tree stands are, like coming down and you're landing just on your heel and it just crushes it. So just kind of like an accordion kind of stuck that. Now the CT scan over here shows that there's multiple different pieces. The whole lateral wall just kind of blows out. And we couldn't do surgery again on this guy. He went in and had the Liz Frank done the first week, and then we had to wait 2 weeks because he had so much swelling and had the blisters, and we had to wait till the skin was not compromised. So if you look kind of and touch the outside of your foot, there's not a lot between the skin, the soft tissue, and the bone. So we have to make sure, one of the biggest complications with doing any kind of heel fracture is that the skin gets compromised, and if they slough off that skin or they necrose and it becomes dead, then infection happens, and then we're just in a whole nother problem. So these are intraoperative. These little wires that you see here are just used to hold the skin flap out so that we don't pull on the skin too much. But we have a plate and screws that we put in, and you can see that we get the height back, and all those screws go across, and you have the plate there. So this was the before, and this is the after. A lot of these, probably about 50% of these patients go on to need to have this joint fused because there's just so much damage and traumatic arthritis that forms. So he may or may not have another surgery in his future, but definitely a whole lot better than that. That's not a functional foot. So just a couple cases that we have here, and then we'll go back. So this is one of those gangrenous. You'd be amazed how many people let that go for a long time, and then they finally come in, and then they go, really, there's a problem? Yes. It smells awful. That awful smell is what you don't want to deal with. This is another complication of diabetes where you can have that neuropathy that we talked about, but it collapses the bone. They have spontaneous fractures and dislocations. This unfortunate soul met his match with a trash truck, and he lost the front portion of his foot. I have the first slide, I'll show you that. This is a before and after. Before, you can't see this real well, but there's a bunion on this side and a bunion over here. Bunions are the bumps. We had to realign it and straighten everything. We do simple things of helping people with their toenails too. My resident thinks he's funny. That's him right there. He puts himself in the slides. This is just doing a bunion. Here's a different ankle fracture that we have. These are multiple metatarsal fractures. Remember I talked to you about having that fellowship in Russia? This is the type of framework. It's a very specialized type of fixation that we use, that if we can't get something on the inside, we have to use something on the outside to stabilize fractures. This is a real interesting case I had. A gentleman, retired gentleman, but still working part-time. He felt something pop and his foot just started to kind of slap the ground. He tore a tendon, but by the time he came to see me, it was like 2 months after the injury. So I had to repair his tendon, but I couldn't get it back out to length because it had retracted up in his leg. So as much as I thought I was strong enough to get it down, I couldn't. So I had to use a cadaver. Everybody know what a cadaver is? Okay, it's from a dead body. It's a tissue graft that we use. I had to use a cadaver, and we put a hole through the bone, stuck the tendon in it, and then kind of plugged it so that the patient has a functional foot. So we'll way back to the beginning, because we have a couple more cases, and you guys can ask me some questions now that you all are trying to keep your breakfast down. Again, here's another example of the external fixation that we have to use. This is that Achilles tendon, another surgery. Someone had a rupture, a calcaneal fracture. This is the demise of the trash truck. That's what his foot came in looking like, and that was one of the traumas we had. Unfortunately, he lost the front part of his foot, but that's still a functional foot for a young person. They still can get a shoe, still be active and do things. Over here, just another bunion correction. We see that there's an angulation. That's more of the common surgeries we see. This is another calcaneal surgery, intraoperatively. And that's what I have. Any questions? Are you all grossed out now? Okay. I think the most important thing that I like to tell everybody, there's a lot more, like a lot of people don't understand what we can do. And like I said, when we started, before we had the residency program, when I first started, I've been in practice 15 years. So we've had the residency program 5 years. Our ER call was, we get things here and there, but not that much. But we now, like I said, have increased our ER call about 80%. So we are significantly busier because they know what we're capable of doing. In the past, it was just a very strong orthopedic kind of community in Berks County. Orthopedics does general orthopedics, but they also have foot and ankle specialists too, but not too many. It's kind of a very small subset. But now that they know that we can do this, they send a lot more of that to us. Yes?
The guy with the cut open foot,
got run over by a trash truck. You know how heavy a trash truck is? Pretty heavy. Yeah, so we're not indestructible, unfortunately, when we have, you know, heavy objects fall on us or land on us. Basically, things crush and shift, and it just shears kind of the bone and the skin away. So
Did
his,
he like take off his bone too? Why is the heel still the bone?
so this here is shifted to the bottom of his foot. It should be up here. You see, here's his normal foot. It should, but it was just pulled everything back. So, let's see, I know we have that one here too.
But why is the heel still the bone? If it was shifted?
Well, the heel wasn't shifted down. The front of the foot was. I thought there was a picture of it, but maybe I'm wrong.
Under the pancake. There's a-
Yes, there it is. Thank you. I thought we had it. So you see the whole, that Liz frame joint that we talked about, so the whole front of the foot basically came back here. You see this like prominence here? That's a flap of skin that just kind of pulled back. That should not be there. That should be up on top of the foot. So if you would have been telling me that I was going to do this when I was a senior, I would have laughed at you because I did not anticipate that this is what I was going to be doing. But I do love what I do. And this isn't what you see every single day. This is something that comes in. You know, we split call. I have 7 doctors in my practice. We split call. You know, we only take call once every 7 weeks. So, you know, sometimes it's really crazy busy at the hospital and you're managing, you know, anywhere. Oh, sorry. Managing, you know, anywhere from, you know, 5 to 20 to, you know, multiple patients. But other times it's not so bad. We don't have that much call. So good luck with your studies. Keep working hard. If you guys think you can do something, keep working at it. You will fail at times, but I think the most important thing that you know, you have to have multiple failures to actually get a success in life. If you never fail, then life's boring. But don't stop believing in yourself. I think that's really important. I had a conversation with my daughter. I had a classmate of mine tell me, when I was in college, we were talking about classes and we were talking about organic chemistry. It's a really tough class. And he said to me, a high school classmate, he said, I didn't think you were smart enough to be a doctor. And I kind of looked at him and I said, you know what? It's about how hard you work. And I work really hard at what I do. And I still see him around town every so often and I go, really? Here I am. I worked hard and here I am. So it kind of gives you a little bit of satisfaction that you know that you can do something. So don't ever let anybody crush your dreams.